Thank you, Chair. Thank you for being here. Thanks. So, Secretary of State, you said in your opening remarks that more money alone is not the answer, and I couldn't agree more. However, I think that the right amount of money in the right places could well be part of the answer. So let's look at the public health grant. This year, 26-27, I'm sure you're going to tell me that it's 4.4 billion, and that's up from 25-26, which was 3.884 billion. And it's the first multi-year settlement in a decade, so let's welcome that. That's great. However, the King's Fund and others say it still doesn't restore the real value of the grant to where it was in 2016, 2017, and we're all aware of the underfunding and austerity years. But could you please talk to the fact that whilst we are talking about a shift to prevention, and Sir Jim and I have talked about this several times around parallel funding, if local public health funding remains at that historic real terms level, is it realistic from the NHS's perspective that we can actually genuinely shift to prevention? So we'll start with an open question, and perhaps Secretary of State, you'd like to go first, and then Sir Jim and I can get into the funding.
So I think, as we spoke about right at the beginning, the shift toward prevention is a critical part of the 10-year health plan, and part of, for me, what's important is also spending that money wisely, not just how much and not just where, but also spending it well. And I think that means making sure it's focused on effective interventions. You know, what do we know that works in some areas? We should be replicating that in other areas as well. That focus on value for money, I think, mustn't get lost in this conversation, because we need to make sure that it's being spent the right amount, right places, but it's being spent well.
Fantastic, Minister. So if I can just have recourse to my previous colleagues when he talked about spend to save, if we were going along the lines that you just said, in terms of return on investments, I would put to you that we would shift a significant amount of the funding that's currently in the acute sector into the preventative sector to get return on investment, as you say, to spend it well. Is that your understanding?
I think that part of the answer here is through the coordination between what, for instance, local authorities spend on public health and what's being spent through the health service in the local area. So as part of the reforms through the NHS modernisation bill, the focus on health and wellbeing boards to bring together local authorities, those responsible for public health, those working in the NHS, and to make sure that those budgets are being spent in a coordinated way is a really important way of focusing on that prevention further upstream to reduce costs later on.
Great, and my colleague is going to get into ICBs and who's sitting on that board quite soon, but if I can just come back to the funding issues, and perhaps, Sir Jim, we can resume our conversation about parallel track funding. So if we've got all the money or a lot of the money in the acute sector and we've got historic low spend in the public health area, could you please set out for the committee how you see that shifting to a point where we are running parallel tracks, i.e. we're investing in prevention alongside keeping our acute services going? And I'm going to ask Sir Jim, because we've had this conversation in previous committees.
Good to continue the conversation. So the way I see this, it's really at the heart of the neighbourhood work as well. So it's hard to talk about these things in isolation. The approach we're trying to follow now, so just to illustrate, if your DGH in a normal place would spend about £3.5 million on running a ward, if we can get neighbourhood health powered up and those people who shouldn't be in that hospital setting could be looked after more locally, that will also save money, is the gamble that we're making. And you know that £3.5 million in a place, so in a council area, would buy a huge amount of prevention. So it would buy the services that would be required around frailty or whatever to stop patients being in hospital, but there'd be money left to make a material investment on prevention.
Okay, I think I understand. So you're basically saying the money's going into the neighbourhood model.
Yeah.
That's secondary prevention, also very welcome. And do you know what proportion of NHS England's current budget is spent on prevention? Do you know that?
No, not off the top of my head.
Do you think you can find that out?
I can do, yeah.
That would be really
I was going to just there's a second step from the one I was just describing there as well, and there's a constant challenge in all this about how long we can allow the service to find new patterns of care so that the money gets redistributed and patients end up in the right place rather than in the expensive places as currently the case. It's a live tension. And the alternative is we do it entirely allocatively, So we actually just shift the money. The risk of that is you leave the patients and the deficits in places who haven't managed to change the care model. So what we're trying this year is still another year where we're trying to see enough shift in money starting to get in the right places because patients are in the right places. But I just want you to understand there's a live argument every day of every week about how long we can continue with that versus just actually saying we're going to spend less over there, ICBs will commission more over here.
No, I
and we all
understand
have
that.
to sort it out.
There's a choice. And from a political point of view, obviously we're committed to reducing those waiting times in the physical setting, the mental health setting we're going to have another conversation about.
Yeah.
Is there a tension between hitting those waiting times and meeting our strategic objectives on prevention, on that shift to prevention? Is there a tension there?
Yeah, everything we do, there are tensions with. So that, and with all of this, we talked about a lot last year, the amount of financial heavy lifting that we've had to do and getting the money back in order. Every day of every working day, colleagues are working with the tensions and the trade-offs. So we're not absolutely not out the woods yet and all that. No. And you can feel that. So I talked to ICB chief execs, I talked to mental health chief execs yesterday. There is an anxiety about how long are we actually going to be able to withstand this before we start seeing some breakthroughs. And I really think that's what this year is about.
Yeah, thank you. That's honest. And Secretary of State, if the scenario was that in order to invest to save in prevention programmes meant that we would have to revisit the waiting list targets for our physical ailments, is that something that you would consider?
I don't think it's that binary. It's not. We've got to...
According to Jim, that the tension is there.
No, I think I don't want to put words into Jim's mouth, but I think what Jim was saying is there is a tension within budgets. Of course there is. I mean, there should be tension within budgets. It would be wrong if there wasn't, because it would mean that you're spending money too loosely. There's a huge tension within the budget because we want to get value for every pound that we're spending. I think there are two separate points there. Firstly, there was the one about how do we hit the targets we've made, particularly around electives and waiting list times and referral to treatment times. That is one which, yes, the investment is important, but the reform and the modernisation I spoke about earlier is critical as well to helping with that. On the other side, making sure that public health money is spent in the right places, but also spent wisely, is important for bringing down that demand in the first place. So I don't see it as being a direct trade-off. I think they if you can reduce demand through greater prevention, that is better for the waiting lists.
Well, arguably so, and also the underfunding of public health. There may well be a tension there in that you might have to think of a trade-off in terms of you might have to put more money into prevention, and where does that come from? But that's probably for a future conversation. If I could just move very quickly, because time is running, to some of the issues in the broader prevention world. My colleagues also already talked about obesity, but if I can take it one step wider and talk about the health mission, that I'm not quite sure where that's got to now, but let's park that word and talk about the cross-cutting issues in health, and particularly the commercial interests that shape so many of today's biggest health challenges. So I'm sure you already know the Secretary of State, but the cost of unhealthy food, the advertising issues around junk food and the branding loophole that we've discussed, but things like addictive gambling products, addictive design of social media platforms. When the department is making policy, does it now explicitly consider these commercial determinants?
Do you mean the challenge we might get from commercial interests in pursuing certain policies? Is that
yes, and also when you are determining which policy has priority, do you routinely think about these broader issues that are bearing down on our health?
Well, I suppose, if you think about food, for instance, I know it could apply to other aspects of our life, but if you think about food, the right way to make policy, in my view, is to work out, what is effective, what is the right thing to do, how can we best get to the goal that we're seeking to achieve, then work out, which stakeholders might have a say in this and how can we work with them to shape the policy in the right way, but also be clear what we want to do, because engaging with stakeholders doesn't mean that everyone agrees with you. It does mean it's worth listening, because they might point out some obvious ways in which we could do things differently that would be mutually beneficial, but it's about having a clear political direction on this and making clear that some stakeholders might not be entirely happy with what we're doing. That I was responsible for tax for a year, I know that dynamic quite well.
Good, excellent. I think it'll be entirely possible that commercial determinants will feel exactly the same about your Secretary of State. So very quickly, in the same way that you would assess economic impact incredibly thoroughly, would you look at commercial regulation and assess the health impacts of commercial regulation?
Well, I think there's obviously a relationship between them there, and I think
Is that a yes? You would look at health impacts of commercial regulation alongside economic impacts. Would you look at both?
Which commercial regulation are you talking about?
Well, any commercial regulation that you might think about, would you think
that would not
about
be,
whether...
That would not be just from the Department for Health, though.
But in your role as Secretary of State, is that something that would come across your desk? So commercial regulation, you think, for example, in the food department, obviously there's an economic impact of restricting certain foods or restricting advertising or, allowing supermarkets to behave in a certain way. There's an economic impact. How far up the agenda is the health impact of those issues as well?
Well, that would be why I would look to pursue various changes in regulation, because of the health impacts, and I would be mindful of the economic impact as well, and I would look across the piece. But with my very clear hat on as Secretary of State for Health, the reason why it would be on my desk, I would ask for it to be on my desk, is because the question I'm asking is what can we do to help tackle childhood obesity, for instance. Now that may involve changing or introducing or amending or whatever commercial regulations.
If there's conflict with the economic impact, how does that play out? I mean, I know you're new into your role, but obviously you had a previous role.
I don't think there's anything new to say there are tensions and choices you take in government. I mean, you've always got to balance off different factors. I mean, that's the job, right?
But our job is to put health first, and let the economy follow us. So just checking in on how that is with you.
My job is I would initiate things because of health, but I don't think it would be right for me to ignore all the other impacts and decisions I take. So, if I ask for a proposal about changing something in relation to the way that food is advertised at children, for instance, that will be because I'm motivated by improving the health of young people. But I wouldn't take that decision without thinking about the wider context, and that's kind of inherent in government and good government, that you think about the broader context of all the
decisions. But good to hear that health would come first. Sorry, Jim.
Just to add to that, if there's another part of government proposing a change in the regulation of some part of the economy, and we were involved in right round, James and colleagues, we'd be very clear about what we thought the health impact should be in that consideration. The call wouldn't be ours, but would make our views clear.
It would almost be like a health mission, wouldn't it, Jim? Thanks so much. Okay.